Hello everyone, welcome to the channel. This will be a pathology video on complications and chronic ischemic heart diseases. So the complications will be of ischemic heart diseases by Dr. C.S.B.R. Prasad, Professor of Pathology, Sri Devaraja's Medical College.
Prognostic factors, there are certain factors which are associated with poorer prognosis for acute myocardial infarction, that is advanced age, female gender, diabetes mellitus and previous MIs. It is a cumulative effect. And what are the complications of MI? This is very important. Contractile dysfunction. The patient suffers from cardiogenic shock because of pump failure, and the patient may land in arrhythmias when infarction or the necrosis involving the conduction system, and myocardial rupture. This flabby muscle can rupture easily, and ventricular aneurysm. If it survives, there is fibrosis, probably it may bulge producing ventricular aneurysm, and pericarditis because of any necrosis, overlying pericardium shows the fibrinous pericarditis, inflammation and fibrinous pericarditis. Mural thrombi because of the lining epithelium is damaged in the case of myocardial infarction, and because of this lining epithelial damage there is thrombus formation within the ventricular lumen. You will call this as mural thrombus. That is the potential source for thromboembolic manifestations. And if this necrosis involving the papillary muscles, probably papillary muscles may rupture, causing sudden appearance of the incompatible or regurgitant valves, and so any appearance of new murmurs in a patient who is suffering from acute myocardial infarction probably tells you that papillary muscle dysfunction or papillary muscle rupture may be the cause for this new murmur. And progressive late heart failures. So chronic IHD, usually they present with congestive cardiac failures because of small infarcts occurring over a period of time, which may not bring the patient acute fashion. So this image shows that the myocardium ruptured at the site of infarction, and ruptured myocardium can pump blood into the pericardial sac, and accumulation of blood in the pericardial sac with associated the compromisation of the cardiac contractility is known as cardiac tamponade. And again you see this papillary muscle rupture, and this is the surface epicardium of the heart showing reddish discoloration and fibrinous exudate. So this is known as fibrinous pericarditis, which can occur after weeks of the myocardial infarction. And these patients develop what is known as the chest pain, and there may be pericardial rub which synchronizes with the heart sounds, and this may result in what is known as rise in ESR and other identifiable things. So delayed pericarditis occurring 2 to 3 weeks after myocardial infarction is known as Dressler syndrome, and precipitating factors like NSAIDs or anticoagulants, and they respond very well to salicylates. So chest pain is the clinical manifestation, and fever, malaise is another thing, and these fellows may have rise in ESR. You can see that myocardial infarction with a mural thrombus sitting or attached to the ventricular lumen, and this is a healed myocardial infarction where you can appreciate the presence of whitish discoloration and thinning of myocardium and bulging of myocardium. It is aneurysm of the ventricle. This is again arrow represents the bulged myocardial, the infarcted area or fibrosed area. So aneurysm, ventricular aneurysm, and this ventricular aneurysm produces what is known as seesaw movements that can be clinically appreciable in any patient who suffered from myocardial infarction. So the person with acute myocardial infarction develops seesaw rhythm, which can be appreciated by examining the chest. Tells you that this patient might have developed ventricular aneurysms. So chronic ischemic heart disease, there is progressive. This patient comes to you with congestive cardiac failure. It is due to accumulation of multiple ischemic events which are smaller in nature, which may not bring the patient to you in acute fashion. So there is necrosis of the tissue over a period of time, small areas, and this will be replaced by fibrous tissue, and in the course of time the cardiac muscle fails to perform its duty, and the patient will come with congestive cardiac failure. And chronic IHD morphology, there may be cardiomegaly, and there may be If you look at the coronaries, probably the patient may have stenotic coronaries, and discrete scars can be appreciated, and even the endocardium may show fibrous thickenings, and mural thrombi may be there within the ventricular lumen. Microscopically, you will see myocardial hypertrophy of a viable myocardium, and fibrosis. Small areas of fibrosis can be appreciated to be spread widely in the myocardium. And chronic IHD is seen most commonly in elderly patients, and they may not have the history of previous MI, and they may have a history of bypass surgery, and severe obstructive coronary artery disease may also bring the patient with chronic IHD, and without acute MI or healed MI also may bring the patient with chronic ischemic heart disease. Clinical features, CCF is the clinical manifestation of these patients. So sudden cardiac death is the last feature of ischemic heart disease. The patient may die within 1 hour without any obvious precipitating symptoms, and this patient was apparently normal, suddenly collapsed and died within 1 hour of the development of whatever the symptoms or the event. So this is due to cardiac cause. When a cardiac cause underlies sudden death that occurs within 1 hour of onset of symptoms, we will call this as sudden cardiac death. 80 to 90% are complications of IHD, and 10 to 20% non-atherosclerotic causes like myocarditis, cardiomyopathy, long QT syndrome, which is congenital, or arrhythmogenic right ventricular hypertrophy, or some of the examples for this sudden cardiac death. Thank you very much.
Thanks for watching. Do subscribe to this channel.